appreciate you all for being here. I think for some of you it's been a short lunch, so thanks again for your attendance. We're going to open our agenda first with a brief discussion from Kathy Perkins about some wonderful EMS news.
Yes. Some of you may have seen the recent articles in the Houston Chronicle about EMS Medicare fraud that's going on in that area. We've known that it was happening for the past few years. We've also known that there's been some other issues in the Valley areas. But this was a pretty scathing article and had a lot of issues in it. Now, the big responsible party for this, of course, is CMS. But my boss, Dr. Lakey, the Commissioner of Health, wants us to look at this and see if there's things that we can do within our rule structure to address the issue. So let me give you a few statistics that I think you'll find interesting. Right now, in Harris County alone, there are 396 licensed EMS providers in Harris County. In the Health Service Region 6, which is a little bit bigger area, there are 569 licensed EMS providers. In the whole state of Texas, there are 1,241 licensed EMS providers, so almost half of them are in that Health Region 6. At this time, we have 74 pending new EMS provider license applications for that area. Within the last number of months, our staff have started to see a trend of many of these providers not having a medical director. And one of the decisions one of the things we've already indicated that we're going to start doing, if on an inspection we find out a provider does not have a medical director, we will emergency suspend the license. If we find out they didn't have a medical director sometime in the past year for a number of months, which we also finding, then we will bring fines to bear in those kind of situations. As I said, Dr. Lakey's very concerned about this issue, and he's asked my staff to come up with a plan for how we can address how we might address this, some proposals. There may be things that we need to look at statutorily. There may be things that we can look at from the rules perspective. I've also had a very brief discussion with the executive director of the medical board, and I'm going to try to have a meeting with her sometime in the next month or so to discuss some of these issues because medical practice is regulated by the medical board, not by us. So we really need to be a partner in collaboration with the medical board because we're finding things like EMS medical director having 71 firms under them. If you look at the rules that are required, the rules under the medical board for a medical director, it would be very difficult, I would think, to meet those requirements with 71 firms under you, and 50 firms, and even 30 firms. What's going on now, just so you kind of understand what's happening, and it's been happening for a number of years with kidney dialysis, and basically they'll get a physician or they'll forge a physician's signature that a kidney dialysis patient must be in an ambulance to go to and from their dialysis appointments. Rarely is that necessary. At 3 times a week, that adds up very quickly, and they bill Medicare for that. What's happening now is a little different. They're taking people to community health centers that aren't even licensed. And some of these turn out to not even be community health centers. They are storefronts. Or they bring them into this room and they sit and chat for an hour or two, and then they get back on the ambulance and go back to wherever they started. There's no real true care, and these people do not need to be in an ambulance, obviously. The other thing that they're very smart about doing is they know that there's a threshold where the FBI will, it's just not big enough, okay? And we've understood in the past it's around $1 million. We don't know what that is in fraud, but they're very careful. We're also seeing they own not only an EMS they're not only an EMS provider, but they're also a medical device provider, as well as, home health. Home health. So they'll be doing all three of these out of the same place with the same phone number, okay? So we're looking at probably doing additional inspections, but you know we do have limited staff. So I wanted to give you a heads up because we're going to be working on this plan with my boss. We'll be bringing back to you, maybe by next meeting, ideas for potential rule changes that might help, help some of this. And then, we see where we go from there. But I wanted you to be aware of it. And frankly, this gives EMS a black eye. Most of these are not 911 providers. And not only if we don't get it cleaned up, then CMS may come down, and that's going to impact everybody because they rarely just do something targeted toward a specific provider. They will then come down on everybody, which could delay billings and things like that. So who knows what could come out of it. So we really need to work in collaboration to try to address this issue. Are there any questions for me?
Kathy, I understand some of these doctors are making like $500 a month for each of 70.
For each of their provider, yes.
So that's $35,000 a month. We're going to need some pretty strong political power. They'll be hiring some lobbyists that we can't afford at that rate.
Yeah.
But we'll support, we've wanted more regulation forever.
Mm-hmm.
And the fact that we've tried to get the Board of Medical Examiners in the past to even just make a checkbox so that every year when you fill out your renewal that you just had to put whether you were an EMS medical director, and they wouldn't do that. So years ago, we went to the Board of Medical Examiners to see if they would just add a checkbox on the annual renewal to say that I am a medical director for an EMS system, so that we could get better demographics. And so that's what we're coming up against. Maybe I think they've had some new leadership at that level, and I would totally support any changes we can make.
And there's
mandating courses or whatever we need to do.
And some they're going to have to do. We're not going to be able to do it. They're going to have to be the ones. So I'm going to have this first meeting with her, with the executive director, and then we'll take it from there and see if they're willing to look at some of these issues from their side of it. But in the meantime, Dr. Lakey's asked us to see what we can do within our swim lane, and we're working on ideas that will be probably coming back through you guys.
Great.
Okay? All right. Well, thank you all very much.
Thank you. I'm going to skip over item number 1. I want to see if I can find a resource for you guys. Let's go to number 2, update by EMSC on pediatric protocol review.
Yes, thank you, Tony Gilchrist, EMSC. Just a quick review. You should have in your documents a set of questions that we put together for a research literature review process. As you know, this has been an ongoing process, painstakingly slow sometimes, but we did get some funding, supplemental funding this year from HRSA, and we are using that for our literature review through the Texas Children's Hospital Evidence-Based Outcome Center. So we're excited to actually be moving this along. What we did was put together with the help of some stakeholders, the help of a review of a lot of the protocols that we have accumulated over the last couple of years from different places around the state. We put together a set of questions based on a couple of things. One of them was looking around the nation to see what evidence-based protocols are out there or are in the process of being developed, and we know that there are now either nearing completion or completed some guidelines for respiratory distress and failure, some guidelines for seizure, and a lot of literature about pain management. So we left those off the table. And so we looked at 4 specific categories. And like I said, you should have this in your documents. This is non-trauma shock, post-resuscitation management, C-spine immobilization, and pediatric non-transport, and put together a list of questions, again, based on, you know, the input that we had coming in, and also looking with the EBOC team at you know, what literature is out there, and what would we have the most success out of in a literature review. And so we came up with these topics, put out this list of questions, and what we're asking everyone to do is to prioritize those questions for us, and then we're going to aggregate that information and take the top 4 questions in each category, give to the Evidence-Based Outcomes Center to do their literature review, which we'll put the first evidence summaries out in the spring, along with whatever other information from around the nation is already published as far as evidence-based outcomes or evidence-based protocols or guidelines, or you know, what literature that we know exists. So we're starting that process and building along. We put this information out on a SurveyMonkey. You should have that information. I can read that address off for you if you like, and I also left a copy out there on the desk so people can look at it. But that's surveymonkey.com/S/SFCYFG. And we'd really like for everybody to go to that site, look at those questions, prioritize them, and you know, the more information that we get back from stakeholders, the more relevant this literature review is going to be. And so we really want to get a lot of information back. We have a very short window of time. We have to present this information to the EBOC team on the 30th. And we really squeezed up. Someone asked in the last committee meeting why we you know, couldn't go to the RACs and let them kind of look over these questions and give us feedback. And the answer is simply that we got this funding over halfway through our year, and we have to use it up before our grant year's out. And in order to do that, we really kind of had to compress time. And so we thought we'd just put this out to all the stakeholders, let them give us their feedback, and then we'll go from there, developing this literature review. And so that's where we're at with that. Like I said, we're pretty certain that we're going to be able to actually have a start on posting evidence-based summaries by the spring of this year. And that'll be, along with what we know for sure will be the respiratory distress management evidence-based guideline that's been developed under a TI grant, and a seizure guideline as well. So that's where we're at on those guidelines. I just real quickly just wanted to mention also, we are doing a couple of surveys, one right now at the conference at our booth, just a convenient sample of EMS providers having to do with online, offline medical direction. And then I'm still awaiting the IRB approval for the medical directors survey, which will be sent out. It'll be an online-based survey targeting all the 911 agency medical directors, that is asking specific questions about the idea of regionalized online medical direction, and you know, questions surrounding that. And that's part of, you know, things that we had discussed in previous stakeholder meetings. And so that's all I have for you. If you have any questions. Yes?
Tony, I looked at the survey, and it's so complex with so many different priorities. I initially thought about it, and I said, I don't know, I'm going to have to spend a weekend doing this survey. This is the first 5 questions. It filled out an entire page.
Yeah.
The first 5. And let me just say, if it goes to my EMS agency and this isn't discussed ahead of time, there's nobody in my agency that can answer this, because it's asking about admission rates and decreased length of stay and mortality in hospital and decreased end organ failure and things that EMS, we can barely get a report from the hospital about whether they lived or died, much less go into that kind of data. It's way beyond an EMS survey.
Right. Well, understand what we're getting at there is, what we want folks to do is let us know what questions they want to ask, because there is literature out there on that.
Send out a survey that says, do you think it's important to have pulse ox? Do you think it's important to have capnography. Do you think it's important to have interosseous? If you think it's important to have interosseous, which of the two kinds do you think is the best? Those are the kind of survey, this is just so complex. I think you're going to get only people who have absolutely nothing to do to fill it out.
Well,
I got through the second question and went,
I hope that's not the case. I hope that people can look through there and see what the intent of the question is. If it's talking about pulse oximetry, what we want to know is pulse oximetry in a post-arrest situation important to you enough
And do I rate it
to
1, 2,
ask the question?
7,
And
or
what we
9?
right, and what we did was develop the PICO questions as they're going to be asked. I tend to want to do it much more simple as well, but we talked about it with Dr. Shaw and Dr. Macias and with the Evidence-Based Outcomes Center, and they wanted to put the questions out the way they were going to be asked so that there was no confusion as to how the question was to be asked
But it's
for our
addressed to
stakeholders.
Dear EMS colleagues. And it doesn't specify your medical director has to fill this out, or your head of education. It doesn't, I mean, how valid is this going to be when you get it back?
This is just a mechanism for us to get from our stakeholders what they think is, of those questions, are the questions that they want reviewed. Because we can only, given our resources and our time, we're going to only be able to review 4 questions out of each of those topics. There are many, many other questions we could ask, but that's kind of where we're at. And I can see your point there with how complicated it is. Like I said, what they were concerned with is if we didn't put it in the language that the question was going to be asked, that there may be misunderstanding with what it was we were going to ask.
Yeah, I tried doing the same thing, and I think I got to question 3 and then quit and deleted the email. I mean, each one of these questions could basically be a funded project, and the NIH doesn't know the answer to any of these. So, one, I couldn't figure out what the questions were. I'm a simple ER doc. You know, it is in English, but that's about it. Second thing was I couldn't figure out what you were going to do with it. So, except for the fact that you said that you were going to run out of your grant money, I'm really struggling with this.
Well, no, this is something we've talked about in the past as far as doing a literature review. And what we've done was we have contracted the Evidence-Based Outcomes Center, that's what they do. They build evidence-based guidelines. They do literature reviews in a very strict research format. And they do literature reviews. And these are questions that, when we talked about it, they felt like there was sufficient literature out there for the most part for these questions that they could provide a summary. But these questions, basically what we're doing is an evidence-based summary of what evidence does exist for each of those questions. Hopefully, the end product is going to be something where you can be a little bit better informed about what the literature does say and what it doesn't say regarding each of those questions.
Any other questions for Tony? Thank you, Tony. Appreciate
Thank you.
it. I'd like to thank Dr. Moore for the segue to the next item. We'll go back up to number 1 about how hard it is to get information sometimes from hospitals about whether our patients are still even alive. I got an email from the CETRAC medical directors regarding a position statement they were creating regarding that matter. And if you'll forgive me for reading part of it, I'll skip some of the preamble. But the basis was that, I'll quote some of this, despite major advances in pre-hospital care, many acute care hospitals do not view EMS as an integral professional part of the healthcare continuum. As a referral physician, EMS directors expect that appropriate information from the receiving specialists/hospital regarding patient diagnosis, outcomes, discharge summary, and critical quality improvement metrics will be shared with them. Beyond the physician-to-physician model, this exchange of health information is allowed by the Texas State Health and Safety Code. Skipping down a little more. Accurate and timely exchange of information between hospitals and EMS services is critical to quality improvement of these services as well as the individual providers. attention to performance metrics related to coronary reperfusion time, stroke team activations and interventions, accurate and timely trauma and cardiac resuscitation management, and survival outcomes are vital to this new age of EMS. The time has come that EMS and hospital information exchange be seamless, taking advantage of this relationship, improving the continuity of care as well as the quality of service to our communities. We will accept no barriers to this exchange. And that is signed by Jay Kovar. And we still have problems. I know I still have problems with that kind of information exchange. Anybody here have a perfectly seamless communication continuum with their hospitals?
I think ours is pretty good. I can't relate to some of the problems you guys are having because we have now 3 of our systems that give us open access to their EMR, so.
Did you have to jump through any particular hoops to make that happen?
Not particularly. I mean, especially now that Stroke and STEMI and other facilities, you know, part of their accreditation is communication and EMS involvement, and so they're more than willing. I mean, we now have every one of our hospitals sending us back nice letters for the crews with pre and post 12 leads, pre and post pictures of the intervention and times and congratulations, and so I think it's been.
That has helped.
What's that?
That definitely helps.
Yeah, no, it's wonderful. I mean, and it may be the fact that we're part of the ROC, so that, you know, we're IRB'd with a lot of them, and the reason they give us open access is because of that. I don't know what the holdups are that some of you are having, other than, I mean, I'm assuming that you've approached the hospitals and shown them what laws are out there and trying to find out what their misunderstandings are. I mean, we've had one hospital that was a lawyer interpreted thing that they couldn't share information, but when we really talked to what their concerns were, they were unfounded, and now they share information. So I don't know. I'm sorry.
I would just say, Dr. Ellerby, and I agree with Dr. Beeson, it's really gotten better in the area of stroke and MI because there's such a significant view from the top down, and they can't get these centers certification if they don't have the buy-in of EMS. But, you know, what we deliver to the hospital is very rarely true stroke or true, you know, true STEMI. So I'm missing lots of data from hospitals, and I get a lot of misconception at the level of the hospital where they view that it is a violation of the patient right to give me information about, did the treatment my crew gave in the field made the patient better? And I don't know whether there's something that we could do in some, I don't know, I hate to say rule change because I'm not a big rule changer, but I mean, really it would help if we could get some assistance from the state to say, listen, this data is not protected in a way to prevent the improvement of medical care in the field. This data is needed to be used to make our patients better.
Jay, was this brought about because of a particular hospital corporation and their policies, a major hospital corporation sending out information?
Well, this actually, part of it's initiated from a health information exchange group in the Houston area. Dr. Escott worked on the majority of this, but this particular statement was really in response to all other responses we've gotten from hospitals, like we can't share data, our corporate system says we can't share data. When you mention about help from the state or statutes or regulations, the help is already there. The regulations are there, the rules are there. It's very clear, very plain. What we wanted to do is to put this statement together to state that it doesn't matter what your corporate opinion in Tennessee says. In Texas, we are entitled to this information. We need this information. We demand this information. You will treat these patients as our referral patients in the same pattern and give us that outcome information. It's improving. Again, I think it's kind of funny that maybe we should adopt something like this or a position statement because it's all there, but nobody's really put it together and said, we have a right to this information. We want to get this information. You're correct. We can get specifics. If we want to know what their door-to-balloon time was, they'll give it to us, but only after the government required they publish that to everybody. And they've said, tell us exactly what you want and we'll work on it. And we're saying, no, we'll give you that, we'll help build an exchange system, but if I come to you and say, we transported Mrs. Jones who had a blood pressure of 80 and we don't know why, I want you to tell me why. I want you to give me that basic information, that protected health information I'm entitled to. So it was really trying to spell it out. The regulations are there. I don't care what your corporate lawyer says. This is what the state says. So again, the state has very clear support of us receiving that information.
Would a position statement from the Medical Directors Committee and GETAC assist?
Any kind of dissemination of that information to all the local entities, the guys in El Paso, the guys in in the Valley, et cetera, to their RACs and to their organizations and their hospitals, they need to know that this is the information that we require, and this is accepted. There are no barriers with this type of setup.
So submitted to the committee, would we be interested in creating a position paper and discussing it and promulgating that as appropriate, or do we think that that's not necessary?
I think it's necessary.
I certainly think it would be advantageous to have that statement fettered through the committee and provide support to many people out there, myself included, with our agencies. So.
Well, if Dr. Kovar doesn't mind if I shamelessly steal from his position statement, I'll work on that and bring something to committee next time, and we can chew on that and try and make something official.
I think a good example is where you use hypothermia for return of spontaneous circulation and cardiac arrest. We need to know the hospital continued that process, because if they didn't, they invalidate the use of it for us.
You also have to know if it's working.
Yeah, I mean, if it works at all.
Because of the Open Meetings Act and just the way things work, I'd actually recommend that you forward that language to GETAC now, the council, and maybe we can actually have a position statement out of the council at the next quarterly meeting. If that's, and I'd have to defer to Maxie and the other people that understand better. But if we just bring it to this committee next time, it would still be another 3 months.
I don't have a printed official copy of all the language to share. I mean, if all that sounded wonderful and appropriate, and we just want to rubber stamp CETRAC's position statement and accept it as our own.
Yeah, it's just a matter of timing. If we can take what Jay wrote that you're recommending and send it to GETAC, then let GETAC consider it next meeting and maybe pass it. Does that make sense?
Jay, can you put that in whereas format?
And Maxie, am I correct? Would that's would. Max, is there a process that we can do that and save ourselves a quarter? Because I think this is an issue we've talked about multiple times. I think we all agree. In order to get this to the council quicker, if we bring it just back to this committee, then we still have another 3 months. We have to wait till we can act on it.
And for clarification, I mean, I'm the chair of the CETRAC EMS and medical directors. This was a combined effort with Dr. First and Dr. Kiss and Dr. Escott and the other people for that CETRAC medical directors piece. So we had, within that realm, reviewed it and felt that this was the most appropriate statement to put out.
Well, and wordsmithing can be done by GETAC, but I would just like to see a process so we get this on the GETAC agenda next meeting instead of meeting after next. And maybe that's not something we have to talk about now.
If the Medical Directors Committee puts forth a position paper, does that require official approval by GETAC itself?
Yes. You'll have to run it through GETAC, of course.
Okay.
Yes, you'll have to run it through GETAC.
So, in reviewing that position paper from CETRAC, I didn't see anything in the language, honestly, that I would change. I don't know how many of you have read it in its entirety, so I guess I'm a little uncomfortable with just saying.
Can we instead then ask to have GETAC have on their next agenda approval of a position statement?
We can give them a summary, couldn't we?
Yeah.
Well, until they see the actual document, it'll be hard for them to approve it. You could talk to them about it, and they can put it on their agenda for next time.
Yeah,
And then vote next time.
yes.
We still save a quarter.
We save a quarter, we save.
Right.
If, otherwise, it'll be April instead of February. Or
Okay.
May, or.
Then we'll make that part of our report that we asked them to put that on their agenda. And then we'll bring back actual format so we can show everybody all the language. That way we can actually approve it, not somewhat sight unseen, although I don't think we'll change much at all.
Or, well, we could send comment. We can all look at this, have it on everybody's agenda. We can send comment, GTAC can act on it.
I agree. But thank you, Dr. Kovar and CETRAC, for the work y'all put into that. I appreciate that. Item number 3 regards the paramedic accreditation item, although I believe that's folded nicely in with item number 7, where we're supposed to review 15732. Any comments for us, Maxie?
You're right. Just to let you know that the Education Committee and the EMS committees actually both voted on the draft of the proposed rule, and it was voted out of there unanimously. So we would like for you all to vote or take some action on the rule also, on the draft. You're going to deal with it, I'm sorry, I misunderstood. You're going to deal with it now, or are you asking me about the draft, or are you just asking me where we are with accreditation?
Well, just the draft. I mean, draft is where we are right now, isn't it?
Right. That's right.
Has everyone had an opportunity to look at the draft language for 15732? We'll see it in small print.
We attempted to make minor changes in the rule. Basically, what we looked at was the requirement for paramedics to become programs to become accredited January 1, 2013. We also put a caveat in there which allows for programs that are not accredited by 2013 to be able to become accredited. We are adopting the new national education standards at all the levels. And lastly, we're taking the word out of basic, and they will be called EMTs, which goes with statute, because statute currently defined them as an EMT. Only rule said they were basics, and we'd like to take that out because a lot of people feel that's a negative connotation.
Throughout the document, it talks about co-AM ESP or an organization recognized by the department. That was just a huge issue at the Texas Medical Board on a different thing. Why is that language in there? Does it need to be in there? And how is another organization recognized?
Well, first of all, COA is the organization that we recognize. We have to put language in rule just in case COA fold, or there isn't anybody else out there to do it. Or if someone come up and they become, I guess you could say, the Cadillac of accreditation, and the state decide to go with them, or as they may use two, because we're a large state. So we leave it in there to keep from having to change it every 3 or 4 years or so.
Who recognized, because again, some of the people in the room know what I'm talking about. This was a huge issue at the Texas Medical Board because an organization was recognized by the state that really didn't reach the same level. So who at the state, or how does the state recognize another organization?
Well, it'll have to go through a process all the way from our office up the chain, in a sense. And it will have to be something the department will say, well, we will recognize them, but also we have to make sure that that organization is meeting the minimal standards that's required. And I know it'll be a while before anybody else can step in and do what COA is doing, I think. But we have to have language like that because we can't have a box ourselves in.
Okay. And I'm okay with not being boxed in. I just want to make sure that a phone call to somebody at the state who goes, oh, yeah, that sounds good, doesn't create a cascade of events.
Yeah, it's not as easy as that.
It wasn't supposed to be for the Texas Medical Board either, and it happened. So that's my concern. What's the safeguard to make sure that somebody, because we know we have groups that are opposed to this, that somebody doesn't say, hey, we can do the same thing, will you recognize it?
And that's why we usually come through the stakeholder process, to let y'all know something's going on.
Okay.
I mean, there already is another organization out there that's trying to circumvent this process. Correct. Now, there's no data known about it other than their name exists. So there is a concern that there will be, some other type of accreditation, whether it meets the same standards or not the same thing I think you're talking about there, Bobby. So what if that alternative thing comes to the state? Is there a process already? Or is it something that would have to be created for them to also be recognized as an accrediting body?
can tell you what we've done in the past, okay? This issue came up with stroke designation. If you're familiar with the stroke designation requirements, that for a primary level, you had to be certified by the Joint Commission. And the Joint Commission is actually identified in the rule. There was another organization that people wanted to use. And so what we did in our office is we actually did a comparison, or actually we didn't do it, TTAF helped us do this. And we compared the program with Joint Commission side by side to the DMV.
DMV.
Did I do that right?
It's DMV. Yeah.
Always end up with the Department of Motor Vehicles when I try to do that acronym. And once we did that kind of a gap analysis and looked at the two programs side by side, what we came up with was that they were virtually comparable in their certification, and so we would accept either or. We didn't approve them. We just decided that from the state for designating the stroke facility at the primary level, we would accept either certification by Joint Commission or DMV. Does that help?
Yeah, it somewhat sets a precedent that's been done in the past, so.
Right.
Any other questions? Certainly would like to entertain a motion to approve or disapprove the draft language for 15732.
So moved.
Second?
We have a motion and a second to approve the draft language for Title 25 of the Texas Administrative Code, subsection 157.32, entitled Emergency Medical Services Education Program and Course Approval. Any further discussion on that matter? Hearing none, all in favor, please signify by saying aye. Aye. All opposed by like sign. Motion passes. I'd like to ask Dr. Moriber, if he would mind, come up and give us a little update on what he's been doing as far as pandemic triage, catastrophic care, et cetera.
This is a very daunting process. I got involved with this, and it has just gotten bigger. In fact, at the first meeting, Matt Minson, who's also a physician, was sitting behind me, and he was drawing these little tents. And every hour, the little tent got bigger, and it got bigger. And I kind of feel like every meeting I have, that tent is getting bigger. This is a huge undertaking. To put it into perspective, let me look up the fellow's name again. He was the FEMA representative at Katrina's, Michael Brown. He said that FEMA will not save you, that essentially people have to be prepared to take care of themselves. We have 310 million people in this country today. We are already almost at maximum surge. We are running 85% of the ventilators at any given time. Any further surge will severely limit our resources. In 1918, there was a pandemic. It circled the world twice. The first phase wasn't bad. It started in Philadelphia. It was recognized in Europe, where our soldiers were. Those that were sick were taken into basically a communal area where they even got sicker. It infected 500 million people in the world, and the world only had 1.86 billion people at that time. It killed 100 million people. So it's about 20% of the infection rate. We have 7 billion people in the world today. They had basically railroads, they had steamships. The mechanism of transportation wasn't good. We have airplanes, we have cruise liners, we have cars, we can go anywhere. In a day, you can go around the world. So 7 billion people. This is an extremely daunting task that we're probably taking on. In view of the fact of the number of infections that can occur, we will not have enough resources at that time. We will have to develop crisis standards, which is essentially what we're looking at. We have to inform the public, we have to inform our people, the medical community, we have to inform everybody. So we have to have good communications, and we have to have on-time communications. So we have to develop the auspices that we have now, since most people don't get their media events by TV or newspaper anymore. It's Twitter, Facebook, it's texting. So we have to also get into this business too, so that we can inform the population and inform our people on an on-time basis and counteract the adverse effects of risk communication that will occur. We have to decide on the principles and the guidelines that we're going to use, which is basically based on the Utah guidelines. The Utah guidelines are very specific. They work out very well for adults. They do not compete person to person, but they compete with the single individual as to whether or not he will get resources. If he does better, fine. If he doesn't do so good, there's only so much we can do. The pediatric guidelines look at what they call pediatric index of mortality, which is based on a communal effect, which is really not a good guideline. So I've asked certain medical ethicists and also pediatric people from intensivists to emergency medicine to come and review these guidelines. So in addition to communications, we also have to discuss what do we do with people that don't have or are not going to be able to have the care that they perceive, because we have to steward our resources. Even though we have to plan to care for our population. So what I kind of lost my thought for a minute. So when we develop these guidelines, we have to take these into effect. If you remember when I advocated for the PULSE, and we went through that, it's since changed to what they call the MOST, the Medical Order for Standard of Treatment. What I wanted to see done, what I've discussed, is what we call a medical order for sustainable treatment, that we can have essentially a, what's the word I'm looking for? Informed consent, where you will be offered these modalities based on your particular individual medical condition. We also have to talk to EMS and our EMS education. There is almost no education in the field regarding infectious disease. There's almost no education on surveillance for infectious disease. And our EMS people will probably be among the first that'll be out there to recognize this, in addition to the people that we have in our emergency rooms and our clinics where they'll probably come. We have to look at what we can do for force protection. We have to protect our own. With people being so afraid to come in and come out of their homes, they have families, they're going to be afraid to come to work. There may be contagion there. They may take it home. So we have to look at elder care. We have to look at child care. We have to look at providing personal protective equipment for these people so they can come in and take care of the patients that need to be taken care of. The Utah guidelines state something like 40% of the population, or 40% of our staff will not show. In actuality, there have been studies showing as low as 26%. In 2002, there was a case of monkeypox. It was misdiagnosed as smallpox. One RN and one physician volunteered to take care of the patient out of a staff of a couple hundred at a hospital. So we don't know where it's going to be. We don't know if it's going to be 1%, 50%, or 80%. In addition to that, we have to decide what we do with long-term care facilities. We have to talk about alternative care sites, because we're not going to be able to hospitalize everybody that's sick. They may need care, and we may have to turn to other institutions or other hospices to open up beds in auditoriums in schools or in someplace else, and find the staff to take care for these people, and additionally talk about palliative care. So this is a very far-reaching effect. We're going to go ahead with our discussions. Our next meeting is on December 9th, and there's several members of this committee that are on that, and we'll keep you informed as time goes by.
Any questions for Dr. Marburg? We appreciate the update. Thank you. I know that it's tough work you guys are doing. Dr. Malone asked us to bring back to the table, just for an update, the 2009 National EMS Education Standards Gap Analysis. Dr. Malone, take it away.
Yes, sir. This is really just an update for the committee, and Maxie, if I'm not telling it correctly, you help me out with this, will you? So we saw the gap analysis first last year, was presented to us, and if any of you have looked at that. So this is basically a document that was drafted by the National Association of EMS Officers. And so this is an analysis of the skills that are used across the EMS system. And so what has happened in the Education Committee then, and also EMS committee has had an input to this, and many others have, but the Education Committee worked really hard on looking at this gap analysis, and they actually made 3 changes. And you'll see this, if you take a look through here, you'll see the 3 changes are, and remember now, this has to do with skills. So this is comparing Texas to the set of skills drafted by the National Association of EMS Officers. That's what this is. So we, Education Committee, thought we should eliminate the mask trousers. We should add the inclusion of urinary catheterization by both AEMTs and paramedics. And we should include venous sampling for AEMTs and for paramedics. So the Education Committee voted to pass their recommendation on to the full GETAC committee. And so what I'm giving you guys is just sort of the update. If you look at that and have any questions, we'll ask Maxie.
Item is open for discussion.
I don't think we need to have any particular action on it. I really just wanted you to see the hard work that had gone into this. And since we are the medical directors sort of signing off on all these activities, this process that they went through was very arduous, and I commend the Education Committee for that work.
Absolutely. Any questions or concerns?
Thank you.
Seeing none, we'll move to the next item, a presentation from Registry Solutions Work Group.
Hello. Oh, good. How are y'all doing this afternoon? I'm going to give you an update on what the group's been doing since our last presentation. But I'm going to give you a little...
Mean to kiss it.
Oh.
Yeah.
I thought you said I did.
No, you do.
Sorry. I thought she told me I didn't have to get close. Okay, I'm going to give you a little update on what the group's been doing since our last presentation. And I'm going to start with a little bit of what our objectives and the steps that we've gone through. And our group was put together as a means for stakeholders to communicate with DSHS and for us to work with them to get a registry that gives every stakeholder what they need from a Texas registry. Our objectives, we started out with the request for offer. We looked at all the things that are in the current registry, all the things that are in the NTDS, all the different sources with our work stakeholders that we could put together. And this is just a list of some of the people that have been working with everybody to put this, to make progress on this. So what we're doing now is we're looking at the reports and what people may need from the registry once it's up and running. And so Conciliant, which is the group, the corporation that got the RFO for the new registry, will build our most complicated reports, and I believe at this time they're going to build 10 reports for us. Then DSHS personnel will be taught to build other reports, and they'll have the ability to build them as they're needed. And then the users, which are all of us stakeholders, will have the ability to create queries and save that query, and then everybody else will be able to see that query and use it to run reports and pull data on patients that they have the authorized access to. And that way, everybody will be able to run de-identified reports based on maybe county or state against your own facility. So it should be real user-friendly. And the way we started looking at all the reports that are currently in the Texas Registry, and we looked at NTDB reports, we looked at NMSIS reports, we looked at reports that are generated by the TBI and SCI, and also the reports that are run for this meeting. Current reports in the registry right now, the Texas Registry, are the ones that are listed up here. These reports will still be available. There may be some changes in them, but they'll still be available for everybody to see. And this is the current reports on the EMS side that are currently in the registry and being used. And they will also be available in the end product. And they may change a little bit, but they'll all be there. Okay, so then the group recommended that we keep the current reports, that we allow hospitals to run comparisons, stats, that we allow hospitals to run EMS reports and EMS to run hospital reports, and that we add national data whenever we can so that we have state and national comparisons. So this is kind of an example of some of the NTDB reports that we currently get through that agency. And as you can see, this one gives a comparison by levels and the number of facilities. So how many level ones of all facilities. NTDB report recommendations were allow the comparisons, as I've said before, allow hospitals to compare. An example would be your hospital compared to other hospitals based on trauma designation, or your hospital compared to all hospitals as an aggregate group, de-identified by the service area, or maybe disaster response, hospital size, number of beds, injury rates, vent days. As you can see, this could, really branch out into almost anything anybody wanted to look at as long as they're authorized user. This is an example of some of the NEMSIS reports. This one compares the top 10 patient complaints and the percentage. And they seem to like pie charts. We do bar and line graphs, but. So the recommendation for the NEMSIS reports is basically the same. Allow an EMS company to compare within the trauma service area, within the state, or within the U.S., and basically on everything that's in the registry, they would be able to compare. This is an example of some of the reports that we looked at for the traumatic brain injury and spinal cord injury. And as you can see, this was a report comparing the entity, the RAC, and the state. And this is just a Monk report. This data is not really in there. And the recommendation on this, pretty much across the board, was that we would all be able to compare the data within our state, within our region, within our hospitals, or we could just pull reports for our hospital like some facilities need to do for their trauma designation. And this is an example of the Trauma System Committee report. This is method of payment. And all of these reports would be built based on queries that you could build or queries that someone else has built that fit your need. This is an example of transfers out of RAC to a lower facility to a higher facility, no transports. No transfers, I'm sorry. We also recognize that there will be other types of reports that we may need, like annual reports for EMS and hospital and RACs. An example would be a report that could give you an overview of trauma in Texas per RAC. Also, there will be stakeholder requests. An example is the OEMTS RAC Chair Survey. So our next steps are to begin the process of developing these reports, and each part of this journey is ongoing. And we'll also seek some input from other types of stakeholders like injury prevention coordinators and the drowning experts. We're going to have some more webinars. There's 2 scheduled, one for November 29th and one for the 30th. And email notifications will go out to the stakeholders of these dates and times and how to register and the locations of the documents and how to provide feedback, which is really what this is all about. We need as much feedback as possible to make sure that we meet the goals of this new registry. And if you have any questions, Tammy would be happy to answer them for you, and here's her information. Are there any questions?
Functional is August of 12?
That's the last I heard, fall of 2012.
And that's a soft date.
Oh, it's been a soft day for 10 years.
Any other questions? Thank you very much. We appreciate that.
Thank you.
I'd like to open it to the floor for any input from the audience. Any questions or comments or concerns? Dr. Kidd, we didn't put you on the agenda. Anything important we need to know from disaster and emergency preparedness?
I can give a quick update on Texas Disaster Medical System, kind of where we are, TDMS. We had a meeting 2 days ago before GETAC started. Basically where we are is we're about done with our overview document. We've been working on it for the past year, discussing how public health and acute medical care integrate during a disaster. The document will be an overview. It will have a list of resources that are available for public health and medical response. It will have some organizational structure from MOCS, and whatever recommendation from MOCS is. We've had several requests from people around the state as they start to organize their local and regional MOCS, how it can best integrate with the state. So we'll have some discussion on that. We're working on typing all of the disaster resources. Starting in the spring, we're going to actually have what we're affectionately calling our TDMS Roadshow. We're going to actually be going around to the regions and discussing some of the gaps and overlaps that we've identified for public health and medical response. And that's about where we are. We know that we need to start looking at recovery and mitigation as well as mass fatalities. Those are some big gaps that we've identified in the public health and medical disaster response in the state of Texas. That's where we are. Things are rolling along.
Great, thank you. I had a request for an agenda item for last time. I'm going to ask Mr. Justin Boyd to come. I think he may fill us in better than I can about some topics of discussion that we may find interesting.
Thanks, first of all. What we realized in maybe EMS committee, we brought this up for an agenda item next time. We'd like for you guys to discuss it. We got to looking at air medical services, specifically fixed wing services. If a fixed wing service comes into the state of Texas, they do not have to be licensed in this state to pick up a patient. They have to be licensed in their respected state. The question that was posed that we haven't got a good answer to, besides it falls back on the medical directors, is if a fixed wing service comes into the state of Texas and gets on a ground ambulance and they're providing patient care, if they're not licensed in the state of Texas, can they provide patient care in the back of an ambulance? They don't hold a Texas certificate, so that brings up the question, can they provide care? We posed that question, we've thought about it, we're going to take it to the Air Medical Committee this afternoon after your meeting. We'd like for y'all to put it on an agenda item and possibly have topics of discussion related to that. They say it has to be written, from talking to the state, they say it has to be written some type of medical director's statement in the protocol to allow that to happen. We just haven't seen a generic form or a generic statement or any sort of statement that allows that patient care to be provided by a non-Texas certified licensed person.
So I have a protocol in my system that if we're transporting a flight crew, we are a transport mode, it is not our patient. And so if that individual providing care is licensed in another state, you know, that's technically up to their state. And I guess if you were black and white about it, yeah, they would be practicing without a Texas license, but I mean, it's their patient, and we're simply the mode of transport from point A to point B, so,
Well,
you know.
Rule 15711, when it talks about our EMS licensure packet, states that any patient care provided in the back of the ambulance will be assumed by the ground service.
Yeah, I mean, yeah, if you want to be black and white about it, yeah, but we all know that I mean, people get transported every day in the back of ambulances with nurses, with other types of care that the EMS system medical direction is actually not part of that care. It's a mode of transport because they passed a rule that says any patient that can't sit up has to be transported in the back of an ambulance, so.
And that's just kind
You're
of...
right, it needs to be clarified. You're right.
Yeah, and as a physician in Texas, we can't authorize somebody who's not certified by the state of Texas anyway, so you got to go through that step to begin with. So, I mean, even if we wanted to, we couldn't.
So this little circumstance would be a good subject for discussion next time around, and so it will appear on the agenda for our next meeting. So thank you very much. Any other comment or questions from the audience?
Steve, another subject for discussion came up during the EMS committee, in which I think Maxie thought we had brought it up, but I don't think we brought it up. Is that right, Maxie, about the...
It was a doctor, okay, I got you confused. Actually, it was the cardiac committee. One of the requests that they, we asked for suggestions for rule, and one of the suggestions they made was to require persons to maintain their National Register certification.
Oh, yeah, there were a bunch of recommendations yesterday in cardiac committee, and wasn't just National Registry. They also put in ACLS, specifically ACLS as a requirement.
Okay. Well, that's what, he's asking what education, EMS talked about, and that was on their agenda, so, yeah.
So where are we with that? Is that just going to be put in to be looked at in the future?
Well, it's a recommendation. We'll have to take a look at it along with the other 400 and some recommendations we got for rule change, and we'll see what happens.
It seemed that the predominant discussion at the microphone was against that concept, mainly for people in far west Texas.
Well, yes. Of the people that were here, you're right.
Yeah.
Shall we put that on the agenda for next time?
It's a good discussion.
All right.
Again, I sat on the EMS committee, and that was brought up, that is a discussion. We'd also like to extend from the EMS committee, if y'all would like to participate in discussion about that topic, we would like to invite you to the table to discuss that as well, as far as requiring people in the state of Texas to maintain their national registry. We haven't seen any cost-based analysis yet or anything like that, so we'd like to discuss that really in depth before we move forward.
Thank you. Dr. Kovar.
I guess most of the panel is pretty much already aware of it, but our responsibilities as medical directors are to make sure that our crews under our delegated practice maintain at a minimum the state requirements. But anything over and above that, we can prescribe. So if you want your service to be ACLS or you want your service to do something else, that is up to you, as long as they're meeting the minimum. If the state has set a minimum number of hours and you want to double and triple it for your service, you can double and triple it for your service. So this is really the medical director's, prerogative to set those types of levels. In that place, being, staunchly independent, I would caution the state about, prescribing, different particular courses that would take away my ability to direct that education to where I felt it was needed in my area.
Thank you.
It didn't seem like the state was necessarily pushing this idea to start with.
Well, it was a suggestion from some stakeholders, so we'll take into consideration. Of course, we have things that affect us fiscally also, so we take that into consideration too. So, but we will also take in consideration people that are currently not nationally registered. What will we do about those? So that's the discussion that will take place for a while. Everybody will have a chance to really chime in.
Thank you, thank you. All right, last call. Anybody else have something important for us to discuss today?
Mr. Chair, we do have just a couple of informational items from the national level with the EMS Committee of the American College of Emergency Physicians. There's a number of our folks involved in interactions with the federal government regarding DEA regulations and trying to standardize some of the processes that are in place that we've had discussions about here in Texas, as well as the EMS Culture of Safety Initiative. The first draft of that report will be released. I believe it's the first or second week of December. We have a meeting that will be an opportunity for people to provide input. And I know that Dr. Beeson is working on some of the drug shortage areas at the federal level. We'll be working with that and other issues.
Yeah, the only other big topic right now is alternative use of paramedics in non-traditional roles is something that they're really trying to get a idea and grasp on.
Y'all will keep us updated on those items? Great.
Yeah, as far as DEA and DPS, we're going to hold a workshop in Bell County through Temple College, trying to get DEA, DPS together. And our services, we have a smaller area, so it's easier, and we're going to try to kind of get a handle on all of this and then hope to bring something forward to help everybody else in the state, because we just had the TSEP meeting and had DEA and DPS there, and I'm not sure that helped a lot. Seems like it just confused everybody more. So Jeff Jarvis, who's in the back of the room, is really spearheading this, and hopefully we can bring something of use to everybody else.
And we should all wave at Dr. Jarvis back there in the corner, since he'll be joining this committee at the next meeting. Glad to have you aboard. Okay, last call. Is this someone venturing toward the microphone or just to a seat? Nope. Seeing no one else rushing for the microphone, we're going to adjourn this meeting early if I can get a motion to do so.
So moved.
Second.
We appear to be in favor. Thank you very much.